So sometimes you see these kind of questions that you have to use your knowledge, use your content. You try not to memorize it and trying to figure out what the examiner is asking you. And as you can see, you probably know the answer, but if you look at it carefully, you can be trapped by a bunch of information. And as usual, if you watch some of my videos, you know how I approach questions. I try to answer the question before even looking at the answers, right? Which order should the next question? That means there's an order for information here that I need to question. That means something is not right. And you have to look at it and say, which of these information is not right? It's clearly not right that you have to question it, right? So which one is it? A client with acute myocardial infarction is developing cardiogenic shock. Which order should the next question? And what is the buzzword? What is the buzzword for that question? What is the buzzword? If you look at it carefully, what is the buzzword for that question that based on that, I need to question that order? What do you think about it? It's something in the question that should tell you that you need to question the information that is being provided. Patient is in what? Cardiogenic shock. And what is the next do? You receive an order for 0.9% normal saline at 125 ml per hour. Start dopamine infusion in microgram per kilo per minute, right? Obtain a baseline echocardiogram and then urine output. The keyword is shock. Patient is in shock. If it's in shock, then the heart is not pumping. If the heart is not pumping, what do you think we need to do? A cardiogenic shock, the number one priority is to push the heart, right? So dopamine is going to push the heart. So that's good. I don't need to question that information, right? Getting an echo to figure out what is wrong with the patient is a good thing, right? And then monitoring the client's urine output is also a good thing to see if the cardiogenic shock is resolving. But bolusing the individual is a problem. In cardiogenic shock, fluid is not your priority. The problem is a pump problem. So fix the pump. In cardiogenic shock, you want to fix the pump as much as possible. So do something to fix the pump. And that is the best thing you can do for a cardiogenic shock patient. So this is the information the name should question. Too much fluid will put the patient in more cardiogenic shock and pulmonary edema. So this is the information you should question. Dopamine, bedside echo, and urine output are all appropriate. You always have to watch what they're asking you. Questioning something means it's inappropriate and fluid is not good. Okay? Same thing. Which fluid is the most appropriate choice? And this is preparing to administer IV fluid to a trauma patient in hypovolemic shock. If you're in shock, we got to resuscitate you. If we have to resuscitate you, I got to pick a fluid that will stay in the intravascular system, equivalent to your plasma. That is what you use. You use a fluid that is equivalent to your plasma to resuscitate the patient. Which of these fluids is consistent with the plasma? 0.9, 0.44 half normal saline, D5W in water, normal saline, and albumin. Albumin is going to pour water, but it's not consistent with the plasma. So don't pick it. We don't use it as a resuscitative fluid. Abnormal saline is not enough to satisfy. It will leak out of the plasma. Free water is the worst. So the best thing is normal saline. You see, it's all content related based on the information I provided you. Hypovolemic shock. So give them fluid that will stay in the intravascular system. This is a little bit long, but I just want to touch your mind, right? A client arrived to the emergency department in what suspected septic shock. This is the content, right? Lecture. Patient blood pressure is hypotensive with a map of less than 65. Heart rate 125. Temperature 100.2. This is like a case study. I'm trying to, by make it short, standalone. Y count of 18,000. Yeah, it's consistent with septic shock. Lactate is infection. Your lactate will tell you how much perfusion the cells are getting. If it's very high, that means it's hypoperfusion. I told you it's elevated. Urine output is low. All of this is consistent with the individual being in septic shock, right? I mean, septic shock. Now, what do you want to do? These numbers is there to trap you. I give you the answer. I say suspected septic shock. And I give you a bunch of words just telling you patient is in septic shock. Don't see the question and run away. You can't answer it. The blood pressure telling you is hypertensive, heart rate tachycardic, temperature is high, white count is high, is consistent with septic shock. So all these information I give you is the same thing as septic shock. You see how you can get yourself under this question without any problem. And then what happened? I say arrange the intervention the nurse should prioritize. A patient in septic shock, what do you want to do? Draw a blood culture, start norepinephrine, start antibiotic, insert two large bowl IV or IV fluid. If you're on the line, put down your answer. Let me see what you think. What would you do? How would you initiate treatment for somebody in septic shock? Put down, arrange them the way you think it should be done. Draw a blood culture, epinephrine, start antibiotic, give large bowl IV, or start IV fluid. What do you think should be the first thing? And it's based on the diagnosis of shock. A patient in shock is hypoperfusion. And therefore, what is the first thing will you do when you see somebody in septic shock? I need fluid. If you need fluid, which is going to take care of the hypoperfusion, then what? First thing, you need to start large bowl IV. Insert the IV. And then when you insert the IV, you fixed the perfusion issue. Even though they are in septic shock, the number one thing is hypoperfusion. You see the blood pressure is in the 80. Give them fluid. And as soon as you finish giving the fluid, you draw blood culture. After you draw the blood culture, you start antibiotic, then they get epinephrine. So this is the order of preference you have to take care of when you're dealing with the patient in septic shock. Same thing, similar thing. A client is in septic shock as received. Now, I'm trying to see if you get a concept. Patient is in septic shock. We've given them 5 liters in 6 hours. That means we're giving them all the fluid they need. And blood pressure is low, it's tachycardia, capillary refill is 5 seconds. Lactate is also elevated. And that means all this is hypoperfusion. Lactate urine output is low, is long, scattered crackles. What do you want to do? The definition of septic shock is vasodilation. Your vein is now big, it's taking on the fluid. So when you have septic shock, there's a massive vasodilation. So blood stay on your skin. This is why your skin get flushed, right? It get warm, right? And it get hot. This is classic septic shock. Unlike hypovolemic shock, your vein becomes smaller, it get constricted, so your skin become cold. In septic shock, your veins get bigger, but stay there, and your skin gets warmed. And so this is what you got. Now, if I've given you so much fluid, still your blood pressure is low, the strategy I tell people is when you have septic shock, always fill the tank and then squeeze it. Fill the tank and squeeze it. We have filled the tank. We give the patient what? 5 liters of fluid. So enough fluid load is enough. Therefore, after I've filled the tank with 5 liters, I should squeeze it. Which of these is used for squeezing? Norepinephrine is used for squeezing. Giving additional Fluid is not going to help with the situation. Debridement is a trap. It's used to squeeze the heart. We don't need to squeeze the heart because this is not cardiogenic shock, right? Test taking strategy. ABG will tell you hypoperfusion, but it does not solve the underlying problem. So what you should do is to give the individual norepinephrine. A client with an ejection fraction of 25%, that means severe heart failure, is in heart failure, is in cardiogenic shock with hypotension, tachycardia, crackles, basically pulmonary edema, saturation going down, urine output is low. What is cardiogenic shock? All the shock, figure out the underlying problem. Cardiogenic shock is a pump problem. That means your heart is not working. Septic shock is a vasodilatory problem. Your veins are bigger now. So you got to squeeze your vein. In cardiogenic shock, your heart is weak. You got to squeeze it. Fluid will worsen cardiogenic shock. We have a patient with the severe cardiogenic shock. What do you think we should give them? Furosemide, you get rid of the fluid. Increasing your IV fluid, what is going to have it? More fluid go to the heart. It's not a fluid problem when they come to cardiogenic shock. It's because of a squeezing problem. So what do you want to do? Start debridement or give them a normal saline bolus. IV fluid in cardiogenic shock is going to hurt the patient. So B and D are gone. Furosemide will get rid of the fluid and help with the pulmonary edema, but it does not solve the problem. So you need debridement to squeeze the heart because it's a cardiogenic shock. And that is how you can answer these cardiology questions. They are straightforward. Just go with the content. I tell you, buzzword is the key. And you can see what I'm doing. I'm using buzzwords to answer the question. Which additional medication should the nurse anticipate? That means what do you do next? A client experiencing anaphylactic has already received IM epinephrine. When you have anaphylactic shock, it's due to allergies that can cause severe vasodilation too, and they will make your condition very like a septic shock, but it can affect your airway. The first thing you do, they get an epi, right? And if you have a Benadryl, which is diphenhydramine, will also will help with the all those pathogens. They are not pathogens, but these allergens before you can think of oxygen and albuterol. And therefore, the next thing this patient needs is that because he received an epi. If you give them albuterol, you cause the a bronchodilator. But in this situation, it's mostly you got to attack the underlying problem, which is the allergy. Fluid is not going to help you. So they get Benadryl. The client in septic shock is on norepinephrine. Look at it. This is you see, I keep on going back because it's a content there. Now we're squeezing to maintain map of 65. Look at it. Patient is on septic shock. We're squeezing them and their map is 65. Map of greater than 65 is normal. That is your clue. Every time they give you a question, there's something in it that is giving you a clue. I give you a clue that epinephrine, norepinephrine is doing his job. He has given you what? Map of greater than 65. That means your blood pressure should be fine. Your map, right? And then your heart rate should be fine. Your lactate should be fine, but they are not, right? We want to maintain the map greater than 65. That is the idea, right? Right now it's 52 and your blood pressure is still low. Your heart rate is still low and your lactate is still low. What do you want to do? We have not reached the stages that we are supposed to be. So think about what you're going to do. Are you going to give the individual norepinephrine, or you're going to administer more IV fluid to the patient, or you're going to start AVG, or you're going to do dopamine? You know dopamine is not going to help with this, right? But this is the content I told you about. The content related to this is we have a map of 32, and then we want to maintain a map of what? Greater than 65, but the patient is still what? Hypotension. You cannot squeeze them if the tank is still not full. Therefore, these patients, what do you think? If you know your answer, put down your answer. Let me see. We want to maintain a map of greater than 65, but our map is 52. Our blood pressure is in 70. Heart rate is that. Do you increase your norepinephrine dose? Do you give them a bolus of IV fluid? Do you check your ABG or dopamine? The answer is go back to shock. What is shock? It's hypoperfusion. If it's hypoperfusion, give them fluid to improve their perfusion. And this is the right answer. Okay, so this is the things you have to think about. It's easy to say, oh, let me give them norepinephrine, but it's before you squeeze them, fill the tank. Before every time you see a question like that, I want you to think like that. Fill the tank before you squeeze them. A client is in progressive hypovolemic shock as deep respiratory respiration. And the ABG shows what? pH of 7.3, PCO2 of 30, bicarb of 80. What is the most likely acid-base status? Look at the pH. It's less than 7.4. It has to be acidosis. Therefore, we're going to take away alkalosis start from it. So A is gone, and then D is gone. The bicarb is 18. So that means we're chewing the bicarb. So it has to be definitely be what? Something that will chew the bicarb. But the clue you can get is what? Deep respiratory. If you're doing that, you're hyperventilating. Why would you hyperventilate? This is ABG. If you need some ABG, I have a good videos that you can watch them. Why would you hyperventilate? I'm doing what? Hyperventilation. Why would you do that? Because I'm doing, when you're hyperventilating, it's respiratory alkalosis. When do you do respiratory alkalosis? Just flip it. Respiratory alkalosis. When we do that, respiratory alkalosis. You do that if this is metabolic and this is acidosis. It's opposite. Respiratory alkalosis, you do that when you have what? Metabolic acidosis. And therefore, what you do is the right answer is what? Metabolic acidosis. That is why the individual is acting like that. If you're doing respiratory alkalosis, that means you have what? Metabolic acidosis. So this is the problem. Or you can just use the ABG and come up with the answer. A nurse is caring for a client in septic shock, receiving norepinephrine via central line. Which finding is most concerning? Go to the buzzword. The buzzword is what? Norepinephrine. Patient is in what? Septic shock. And is receiving what? Norepinephrine. What do you think? If I'm in septic shock, I'm receiving norepinephrine, my blood pressure should be fine. My map should be fine. I should be peeing okay. Urine output should be fine. So map of 65 is good. I'm not going to be worried about it. Capillary refill of 3 seconds, right? That means it's good. It's 3 seconds. It's not by more than 3 seconds. That means you have issue. Peripheral IV is cold and pale. Think about it. You give you vasoconstriction medication, it's a vesicant. It can go into your skin and causes vasoconstriction, and you have necrosis. This is extravasation. Urine output is greater than 30, 35, is 35 ml per hour. That is good. Test taking strategy. Which one is concerning? This is normal. This is normal. This is normal. That means I got to pick this. This is extravasation. It's from the norepinephrine causing that problem. Which findings suggest that the client is in the early stages of septic shock? This is a good question. I will show you how you can answer it, even if you don't know. Look at it strategy-wise. A nurse is assessing a client in septic shock. Which one is the early signs? Look at it. Early signs, that means you should not show evidence of shock. You see, it's an early compensated shock. Means I've compensated to the shock that nobody will know I'm in shock. If my skin is cold and clammy, that does not indicate that I've compensated for the shock. At the same time, sepsis will not lead to cold and clammy skin. It will be like warm skin. But if you get to cold and clammy skin, you're completely dead. It's decompensated. You can't hold on to that anymore. Your blood pressure is low. That means you are in shock. You have not compensated. Your urine output is 10. That means you're in shock. You have not compensated. This is warm, flush skin is the early sign of septic shock. These are trap, but these are content. In the early stages of septic shock, once again, your veins get bigger and bigger and bigger, and blood stays there. When blood stays there, it makes your skin warm and flushed. When you become hypotensive, you are no more compensated. When your urine output drop, you are no more compensated. When your blood pressure drop, you have not compensated. When your skin get clammy and cold instead of warm, you have not compensated. This is what it means by this is the early stages of shock. Which intervention should the nurse implement first? A client with suspected pulmonary embolism suddenly become hypotensive, tachycardia, and diaphoretic is showing signs of shock, right? But think about it. Pulmonary embolism, what does that mean? Means this is your heart, and this is the vessels, and this is your lungs sit here like that. When your lungs sit here, basically, your lungs sit here on top of it so that blood goes to your lung and come into your heart. And if that happen, it become a problem, right? If that happen, it become a problem. So what would you do? Blood is not going to go into your heart anymore. And what does it lead to? Hypoperfusion. And so in order to prevent this hypoperfusion, you need to provide some fluid to the individual. So yes, the patient will need heparin. Yes, the patient will need norepinephrine later on. But the first thing you do is give the patient fluid because of lack of a decreased preload. So give the individual some fluid. Which action should the nurse take first? A client experiencing anaphylactic reaction to bee sting arrived in the emergency room. I've told you, it's anaphylactic shock. It's what do you think? The first thing you do for anaphylactic is to take care of the allergy. Don't worry about oxygen. Don't worry about anything. Take care of the allergies that are causing the problem. So I know they need a diphenhydramine is the second agent. The first thing you give them is epinephrine. It's number one. And that is the only thing that come basically you go against shock, like anaphylactic shock. You want to deal with the agent right away. So you give them diphenhydramine before even you think about fluid, because the fluid is not going to help them right away. You got to take care of the allergies first. So that's the first thing. So forget about the oxygen or anything like that. Which intervention is a priority? And next, with a client with the spinal cord injury, T4, suddenly become what? Hypotensive, bradycardia, and warm skin. Which intervention is a priority? What do you think is wrong with this patient? He has a spinal cord injury. That's your clue. There's different kind of shock. Is he cardiogenic shock? Is he anaphylactic shock? Is he a distributed shock? Is he a obstructive shock? Think about it. I give you a clue is by giving you the problem. Spinal cord injury, that means it's a neurogenic shock. When you have neurogenic shock, it's a distributed shock. That means your sympathetic nervous system, you lose it, and therefore you cannot squeeze anymore, and your heart cannot even do anything anymore. There's no stimulation. So your heart is now under parasympathetic nervous system. which drop everything. So you become bradycardic. Your skin is like your vein get bigger and bigger. So blood goes there and your skin get warm, right? So that is one of the things you see. That's why they have warm skin. It's a distributive shock. Blood is being distributed to places they're not supposed to be. This is shock lecture that when you watch this video multiple times, you know that this is, there's no question that these are content related to that. So this is the neurogenic shock. And I give you a clue. I told you most distributive shock, the veins are big. If the veins are big, what you do? You fill the vein and then you squeeze it. Fill the vein and squeeze it. So which of these is going to fill the vein and squeeze it? Think about it. First, I got to fill the vein. And after I fill the vein, I'm going to squeeze it. So pick an answer choice where you fill in the vein and then you squeezing it. So do you give them atropine for the bradycardia, or you intubate them, you give them fluid or vasopressin, fill the vein and then squeeze it. So the number one thing, to give it the individual fluid, then you can squeeze it. Anytime you see a question on distributed shock, sepsis, neurogenic shock, think about that. Okay? You can answer that. They are not that difficult. They're more likely to get them wrong, like answer it, if you don't follow a pattern. Stick with the rule. Fill the vein and squeeze it if it's a distributed shock. That means septic shock or a neurogenic shock. In cardiogenic shock, you don't have to fill any vein. It has nothing to do with fluid. Squeeze the heart. So you give them something that will squeeze the heart. Not norepinephrine, but dobutamine, right? Dopamine. Those are the ones. Digoxin. Those are the ones that will squeeze the heart. Which finding indicate a client with sepsis has progressed into septic shock? Test taking strategy. What is the word? I have progressed into septic shock. This is opposite to the other question we saw, early signs of shock. Now I have progressed into septic shock. Pick an answer that shows I'm in shock. What is the problem? It's sepsis. The temperature does not tell you it's in shock. Blood pressure, it means hypoperfusion. That is shock. Heart rate, it does not tell you it's shock. And then why count of 12? It does not. Sepsis can make your heart rate goes up. It can make your blood pressure goes up. No, your blood pressure goes down. And then Y count goes up and your temperature go up. But when you become severely hypotensive, you've developed what we call septic shock. And that is your clue. So this is your right answer. Which assessment finding indicate immediate intervention? A client with severe dehydration, that is hypovolemic shock, right? Due to persistent vomiting and diarrhea. Hypovolemic shock, it means they need fluid. Give them fluid. Which finding indicate immediate intervention? His heart rate is up. It means it's bad. This is B-sharp moment. This is classic prioritization moment. If you need help, check adapting class about prioritization. Immediate intervention is a priority. But ask yourself, which one is expected? They may be all expected, but which expected finding is bad? You ask yourself, is it a breathing issue, sepsis, airway, lethargy, and electrolyte problem? I don't see a breathing problem. I see shock. That is the S. But which finding associated with shock is more worrisome? Tachycardia. Okay, I give you fluid. Urine output is low. I give you fluid. Right? Your blood pressure is low. I give you fluid. But when you're lethargic and you're cold and clammy, that is decompensated state. That means you're not coming back. You have decompensated shock. You have reached a stage that is bad. All of them are expected, but if you put your thinking cap on and you're being sharp, you know, this is worrisome. This is adapting class. Thank you for watching. Good luck and all the best of luck. Enjoy. the day. Bye.